Is it doing it? Okay, you can advance from there. Okay.
So I'll tell you just at the get-go, because we don't have much time, that I think the history is completely irrelevant. It's like a incidental loma. But I saw this patient like a week ago or something, but she's Hispanic. She's new to our clinic. She's a history of alopecia areata. She came to the VA ER with itching of both eyes that was bothering her for years, but over the past like 2 or 3 months, it got worse. She said that her eyes have been red, and she had pictures on her phone showing that her eyelids would just get really irritated and swollen. She didn't identify any triggers. She didn't have any rashes on her body, no vision changes, no painful eye movements. Can you click this slide? So her vision was great, 20/25 in both eyes, and the rest of her eye vitals were normal. And surprisingly, despite all the symptoms she described, she really just had decreased tear breakup time. The anterior segment was unremarkable, but on her pictures, I'll give her that. They looked irritated. And then she hadn't had a dilated exam for several years, so our tech got an optos, and there's something funky, so then I dilated her and got some other pictures.
Right, I found optos photo, attention is drawn to superior temporal quadrant, where there's kind of an irregular round, but yeah, around hyperpigmented spot with kind of like a lacunar hypopigmented central area, where you can see the vessels underneath quite clearly, and then some sort of darker pigmented speckling centrally. The hyperautofluorescence just shows hypoautofluorescence in that same area, round area. Left optos looks normal.
Yeah, there might be like supranasal way on the periphery. You see that tiny little pigment? That might be nothing.
Oh yeah, okay.
Because I don't remember seeing that in real life, but yeah.
So the OCT here.
And I'm just gonna flick through, and then you
Yeah.
mentioned lacuna, which is a nice word to describe that. So try to look at what the OCT difference is over the lacuna versus over the pigmented part of the lesion. I'm just gonna look through.
So it looks thinner in the lacuna area with outer retinal distortion, and shine through, again, suggesting thinning. Yeah, and irregular internal retinal architecture in that area.
Yeah, and if you were to describe that spot like clinically, how would you describe it besides lacuna? That's kind of a weird way of asking the question, I'm sorry, but it's whenever you see it, like, so you're right, there's a lot of loss of just retina period. There's barely any of the black.
Atrophic, right?
Atrophic,
Yeah.
it's
Yeah, some people ask the margins, like, we had 7 things, like margins, company it keeps. Margins with the properly.
When we get here, as you mentioned, the outer retina is lost there too, but it's definitely not atrophic. And I put all the OCTs. There we go. Okay, that's it.
So I think most likely it's like a CHRPE, maybe kind of a chronic one since it has that lacunar area. You know, it could be a nevus, a normal choroidal nevus, and then otherwise a concern for a tumor that doesn't look too concerning really.
How old is the patient?
She was like 30 something, I think.
It's funny using the word chronic for chirping. Because by definition, it should be.
Oh, sorry, I just mean like, yeah, it's been around a while. Or to develop a lacuna like that, I think it has to be like an adult, but yeah.
Yeah, well, yeah, and they're I believe they're all from birth. I mean, it's always hard to like our nevi probably are not from birth. The chirpies really probably should be there when you're born, I think.
And then I looked in JLB and I found an Optom note from 2019, and they listed it as a toxo scar. And then when I saw her, I was like, "Is that a toxo scar?" And I was like, "What the heck? Are we missing something here?" So that's why I got the other pictures, and then that's why I included that on here. But you mentioned a lot of the stuff on the differential here. But inflammation can cause like weird pigmentary kind of deposits, so can trauma, so can drugs. And then can you click in back for that?
Sure.
Wow.
Nice.
Oh, thank you. So, for those of you who weren't laughing, they were laughing because it's congenital. So theoretically, it should have been there for forever, though they can change over time. So they're usually asymptomatic pigmented fundii lesion. The prevalence is 1.2%. And there are three forms. The third form is the one that's like board relevant, they'll ask questions on. But solitary is what it says, is unifocal group, is like a bunch of them together, which I'll show. And then the atypical one is the high yield one. It's associated with familial adenomatosis polyposis. I think that's what the acronym is for. The other name for it is pigmented ocular fundus lesions of fat or pustules.
It used to be Gardner syndrome, but
There is a
it's
it's a subtype of it. So,
it's funny, a lot of things that were named for Nazi war criminals have been renamed. So I wonder if I thought it was renamed, I thought it's another Nazi war criminal.
as far as I know, it's still called,
It's still Gardner's,
Gardner's.
lived a clean life, but.
but in patients who have that, 90% of them will have a retinal manifestation of CHRPE. It's autosomal dominant, with a lot of colon polyps. The mutation, I remember there are 5 letters in CHRPE, so it's on chromosome 5, which is a tumor suppressor gene.
Wow.
If untreated, all fat patients develop colorectal cancer by middle age. And then the subtypes that OCAPs may or may not ask is Gardner syndrome. And if you guys remember, I think it was sketchy. It had somebody who was like bending over to garden and the knees were on the ground. So you can remember there are joint and soft tissue tumors. Along with the fat. And then with Turcotte syndrome, that's fat plus brain tumor. So if you imagine someone wearing a turban, it's Turcotte. So this is solitary unifocal CHRPE, single flat round hyperpigmented retinal lesion. It's usually equatorial, most commonly supratemporal. They can vary in size, but usually 100 microns. Gray to brown black, smoother scallop margins, and then sharp border. And then the retina around it is not. And then grouped or multifocal CHRPE is also known as bear tracks, you'll hear people call it. You can have up to 30 lesions in a cluster ranging from 100 to 300 microns in size, usually just like in one quadrant. And then the lesions typically increase in size towards the fundus periphery and like halos and lacunae. And then the atypical ones, they're smaller. They can, instead of like that round shape, they're more oval or comma shape. People have described like fishtail lesions as well, or shapes to them. And then the thing about them is the benign ones, like the solitary or the grouped ones, they don't affect the retina. These ones, there are bad things happening to the retina around it. With retinal invasion, the RPE is not only hypertrophy, but there's hyperplasia as well, and of the capillary and glial cells too. And it's bilateral in 78% of cases. So that's a huge thing to know for real life. If someone has bilateral stuff, you would consider sending them to get screened for colon cancer. So the histopathology for CHRPE is a monocellular layer of hypertrophied RPE cells, densely packed with large, round macromelanosomes. Brucks can be thickened, and then glial cells replace the RPE and PR layers in areas of depigmented lacunae. And atypical, there's hypertrophy and hyperplasia, as well as retinal invasion, retinal vascular changes, and they can involve the retina in its entirety. So I could only find a histopath for regular CHRPE, not the atypical one, but on the left is the H&E of hyperpigmented RPE, and then on the right, you see the area of the lacuna, where it's all just absent. And then imaging, just to quickly reiterate the things. So on autofluorescence, due to the high melanin content, it should be dark. FA, I couldn't find any pictures of this either, but it would block usually. And then in the areas of the halo or the lacunae, you would expect like a window defect. And then on OCT, so I thought this was cool because usually these are not so posterior, they're more in the periphery, so it's harder to get OCTs over them. But when you can, it's cool to see it. So you see the PR loss over the lesions, absence of the RPE, and a lot of that posterior acoustic shadowing in the areas of the lacunae. So the life-threatening potential that you don't want to miss, and they test on the OCAPs, is if you see multiple lesions, they're bilateral lesions, you should be wary of that. And then something I didn't know, but when I was reading this, apparently, if you're like looking with a 78, maybe with a 22, and you put the red free filter on, a nevi is supposed to disappear, which I'm going to try next time I see a nevus, but the CHRPEs will not.
Wow.
Is that crazy?
It's fun.
And then the prognosis is
Never heard that, I'm gonna try it.
So the prognosis is pretty good, but rarely nodular pigmented adenocarcinomas can arise from within areas of CHRPE. And they can progress to pedunculated tumors that can then cause like CRSRDs and premacular glial dystrophy. That's it.
Nice. Well done. Thank you, everybody. I'll do it. So we are meeting next month and then we're not meeting January, but I'll send out emails and get